Good morning. Today I'm presenting barriers in intervention characteristic of cluster hospital initiative in Malaysia, an exploratory study. This presentation is part of a larger implementation research conducted on the cluster hospital initiative by the Ministry of Health. I'm Dr. Delina, the presenter, and these are the co-authors of the presentation. My presentation today will be broken down into four main sections. First, a brief introduction on the Cluster Hospital Initiative by the Ministry of Health Malaysia and the study conducted. Then I will go through the study methodology and the main findings, and finally the conclusion at the end. Before I begin, a short introduction to set the context of my presentation. Cluster Hospital is a public healthcare transformation initiative started in 2014, merging hospitals to establish an integrated network of specialist and non-specialist hospitals through sharing resources, realignment of services, and enhanced care coordination. Taking example from countries with successful similar interventions such as Hong Kong, Australia, and Singapore, this initiative was aimed to address issues of congested specialist and state hospitals while increasing the utilization of district non-specialist hospitals. Each cluster hospital consists of a lead hospital, which are either specialist or state hospitals, with one or more non-lead hospitals, which are district non-specialist or smaller specialist hospitals. A study to identify barriers towards its implementation from the perspective of healthcare providers was conducted. The objectives of this study were to explore the barriers towards cluster hospital sustainability among healthcare providers, specifically in the 5 domains which were the intervention characteristics, outer setting, inner setting, characteristics of individuals involved, as well as the process of implementation. However, in this presentation, I will highlight only the barriers to implementation found in the intervention characteristics domain. Next, we will go through the methodology of this study. This was an exploratory study using qualitative method. Purposive sampling was used to gather the respondents, and the study was conducted from March till May 2018. Semi-structured focus group discussions and in-depth interviews were used. There are altogether 6 study sites, which were the first 2 batches of cluster hospitals launched to ensure all the healthcare providers interviewed have had sufficient exposure and experience in the initiative. After data collection, the analysis was done using inductive thematic analysis and triangulation based on the consolidated framework for implementation research, which again I will explain in another couple of slides. Across the 6 sites, you can see our study involved a diverse range of professions, from the hospital directors and specialists, medical officers and nurses, to even the medical record officers and drivers. Respondents were also chosen from the disciplines which have started cluster activities. Regarding the inclusion and exclusion criteria, only healthcare providers were involved in cluster activities for at least 3 months and above and have consented to participate were interviewed to ensure they have sufficient exposure and experience to offer a better perspective. Now, what is Consolidated Framework for Implementation Research, or in short, CFIR? It is a conceptual framework developed through systematic reviews which has been widely used both locally and internationally to assess the implementation of an intervention and also to identify the factors affecting its effectiveness and sustainability. As I've mentioned earlier, there are 5 domains in the framework. The outer setting looks into factors outside of the organization, in our case, the respective cluster hospitals, whereas inner setting looks into factors within the cluster itself. Intervention characteristics dissects into how cluster hospital initiative is as an intervention itself. Characteristics of individuals explores about all the healthcare providers involved with the cluster initiative and their contributing factors. Lastly, the process looks into how the intervention is being planned and carried out. All in all, this CFIR framework is a very comprehensive and systematic way of evaluating the implementation of an intervention within the context of where it is being implemented. However, again I would like to emphasize here that in this presentation, I will highlight only the barriers to implementation found in the intervention characteristics domain. Moving on straight to the main findings. There were altogether 57 interviews conducted, whereby 10 were IDIs and the rest were FGDs. A total of 274 respondents were interviewed, and there was quite an equal representation from both lead and non-lead hospitals. This graph shows the respondents' profile by their profession. As I mentioned earlier, our study covered a diverse range of professions to get a better and truer picture. Majority of the respondents are medical officers, nurses, followed by specialists and assistant medical officers or paramedics. Others are occupational therapists, pharmacists, and neurophysiologists. Last graph shows the respondents' profile by disciplines. As you can see, it is quite extensive, from the major departments, subspecialty to even the supporting services. And as expected, medical and emergency department make up most of them, since these two departments were the most common service to be clustered. Now, we move on to the domain which I will be talking about today, the intervention characteristics. Under all the 5 domains of CFIR, there are altogether 39 constructs looking into various aspects. As you can see in the slide, this is the framework together with the short definition of what each constructs and subconstructs mean. So for today, we only have to look at the intervention characteristics domain. Under the intervention characteristics, the constructs are evidence, strength and quality, relative advantage, adaptability, complexity, design quality and packaging, and cost. In the domain of intervention characteristics, the respondents highlighted barriers relevant to only 3 out of 6 constructs: complexity, design quality and packaging, and cost. I will go into the details in the next few slides. The first construct is complexity, and there were a few issues mentioned under this construct. The identified barrier is the pre-cluster relationship between the hospitals. For example, in this statement, quoted from Cluster Hospital A, pre-cluster relationship between hospitals from previous networking initiatives causes much confusion and is a barrier for the staff in cluster implementation. Moving on to the next barriers under complexity was about the geography. Some of the non-lead hospitals especially had problems with poor internet and phone signal coverage, and this greatly interferes with their communication. As we understand, cluster hospital involves a lot of staff and patient movement. Therefore, communication between hospitals were essential. Some innovation like Skype round also couldn't be done. The other perceived barrier is when the hospital is rurally located, and this usually resulted in higher staff turnover. Another perceived barrier is the poor road conditions between hospitals, as cluster hospital requires staff and patients to travel more frequently. This poses safety concern to the staff, and as mentioned here, when equipment needs to be transferred frequently between hospitals, it is risk getting spoiled. The distance between hospitals within the cluster hospital is also mentioned quite frequently by respondents as perceived barrier. When the distance is short, while it helps staff to mobilize, there is a higher trend of patients bypassing non-lead hospitals to seek treatment in lead hospital directly, even though they may stay closer to non-lead. On the contrary, when the distance is long, it will be difficult and taxing for staff to travel daily, especially when shuttle and accommodation are not provided. Another barrier pointed out by a number of respondents is about the need to cover for population outside of the coverage area of their cluster hospital, and this leads to increased workload, which interfered with their ability to carry out cluster hospital activities. There was increasing patient movement under cluster hospital initiative. There were concerns raised by the respondents about medical record management, which they perceived as barriers. The first is about the safety of medical records during the transferring process, as there was a higher risk of it may be lost. The other barrier is the unavailability of medical records in the time of service provision. For example, patient was discharged from lead hospital and have a clinic follow-up in non-lead hospital, but the case note was not available during the clinic appointment. Moving on to the next construct in the first domain about design quality and packaging. There were some respondents who were of the view that cluster hospital initiative may be expanded too rapidly by the ministry. Another perceived barrier is there was a lack of relevant guidelines or policies in carrying out cluster hospital activities. If I can point out in this statement, while this respondent complimented the benefits of bottom-up approach, there were also drawbacks as many decisions were left to the cluster hospital themselves without clear policies. And when there is a change of leadership, for example, hospital director or head of departments, then the decision and direction may change again, leading to a lack of continuity. The next perceived barrier is the mismatched delineation of cluster hospital. There are suggestions there may be a need to relook into some of the cluster whether the hospitals under the existing cluster is really suitable, taking into consideration the geography as well as patients' trend of utilization. Proceeding to the next and last construct for this domain is on cost. Some respondents mentioned that the rigid financing mechanism is a barrier to them as they cannot freely utilize the budget allocation according to cluster hospital needs. Another perceived barrier was the huge capital cost involved for cluster hospital, especially if it involved building or renovation of infrastructure or purchasing of equipment. It was also mentioned the increased operating costs also served as a barrier mainly for the purchase of consumables, especially non-lead hospitals were performing more procedures now, as well as other miscellaneous expenses associated with increased staff and patients mobilization. Lastly, it was also a barrier when staff were asked to shoulder the extra cost by themselves, especially the confusion earlier on whether they were allowed to claim these expenses or not. These are the limitations of the study. The opinions raised in the interview may be limited by respondents' own experience of the cluster hospital implementation, and this study adopted only qualitative approach. Although qualitative data can provide rich information, quantitative measurement for the seriousness and severity of issues raised was not performed in the study. Finally, we are nearing the end of my presentation. Without strategic adaptation, interventions introduced may be unsuitable for local contexts, risking implementers turning down the idea resulting in failure to achieve the desired outcomes. It is crucial to explore the perception of healthcare providers as the ground-level implementers to get improvement measures for the sustainability of the cluster hospital in the long run. Therefore, serious consideration over these factors should be taken both by the external stakeholders and individual cluster hospitals. We have come to the end of my presentation. Thank you.